new deaths in 2022. Looking at the pace we are going, if nothing is done about this, by the time we get to 2030, the numbers will become unbearable. If you look up in the map where I've highlighted, you could see that much of the burden is located in Africa, and especially Eastern and Southern Africa, telling us that areas where we have high burden of HIV, we equally have high burden of cervical cancer, which calls for action. If you look at what is responsible for cervical cancer, one of the key culprit is HPV. That is the human papilloma virus. And we know that this virus is all over the place. It's sexually transmitted. People pick it easily. It clears in the system. But some, it persists, and later on, it turns the cells into precancerous and later cancer cells, and nothing is done. It leads to other situations. We have some of the HPV subtypes that are very high risk, and that is the subtype 16 and 18. And we could see from this slide that about 77% of cervical cancer, invasive cervical cancer cases, are caused by subtype 16 and 18. And then in Africa alone, about 72% of our cervical cancer cases are caused by the subtype 16 and 18. But the good news is that we have vaccine available, and this vaccine can help resolve this issue. And when you look at our last point, is telling us that if you have the nanovalent vaccine, which contains the 9 subtypes of HPV, we can reduce the cases by 92%. So if we have this solution, why are we then waiting for this burden to keep on ravaging our vulnerable population within the continent? If you look at the subpopulation, individuals living with HIV, the risk of getting cervical cancer is 6 times compared with an individual who is not living with HIV. So this will tell you that this particular population is highly, highly vulnerable to infection. And the reasons I stated, they are at higher risk of getting the HPV infection. They have lower chance of clearing the infection. Usually with people who are not immunocompromised, when they get the virus, within 2 years, they are able to clear the virus from their system. But when you are immunocompromised, then you keep getting persistent infection, and with time, you develop precancerous cells, and it leads to other things. Then when they get the virus, they can easily progress to a cancer stage. And then there is no regression within them. As soon as they get to precancerous, they are moving to a cancerous stage. So it's telling us that this group is highly, highly vulnerable to the HPV infection, and they need special attention to address this problem. So if you look at the map, you could see that Africa is always highlighted. And unfortunately, to highlight that our East and Southern Africa and some part of West Africa are the key areas that we are having this issue. And as we are here together as a group, we know by the time we finish this session, we'll be able to come up with some ideas to see how best we can help our people and help resolve this problem. Now, a study was conducted where they were looking at the dual burden of HPV and then HIV in terms of cervical cancer. And when you look at this map, you could see that most of the countries with a high burden, both HPV infection and then HIV, that resulted in cervical cancer, are located mostly in East and Southern African countries, even though we have a lot of other African countries being implicated. So people who have HIV, they have 2 times the risk of getting the high-risk HPV virus, and they have 2 times decreased chances of clearing the virus from their system, and therefore they have higher chance of developing cervical cancer. And the solution is there. The vaccine is available. The vaccine is found to be very effective, and it's working. So what are we waiting for? So getting into the control strategy, that is why we've come together and we'll come out with these policy strategies to see how best we can help address this issue. And one of the arms is talking about the vaccination. We are saying that at every age cohort, by the time they turn to 15 years old, they should have received at least one dose of HPV vaccine to assure them of some protection. And we are saying that by the time a woman turns 35, between 35 and 45, they should have received at least 70% of them should have received high precision screening to ensure that if they have precancerous cells, something can be done. And from those who have been screened, we want to ensure that at least 90% of them should receive proper care and treatment. If we are able to achieve this, then we are on our way, that by the year 2030, at least we would have reduced the burden of cervical cancer by 30%. And this is achievable. The vaccine is available, the screening facilities are available, our hospitals are able to do the treatment. So all we need is to act now. And that is why we are seated here. Now, in terms of the vaccine, I indicated it's working. From these long-term studies, you could see that when they follow people for 10 years after receiving the vaccine, it indicates that when you get the vaccine at a younger age, between 12 and 13 years, you are more likely to avert cervical cancer by 87%. If they received the vaccine at the time they were 14 to 16 years, about 62% of cervical cancer will be averted. And then if you receive it 16 to 18 years, 34% of cervical cancer will be averted. This is obvious that the vaccine is needed at a younger age. And therefore, if we vaccinate our population at a younger age, we will reduce a larger amount of the cervical cancer cases. And therefore, let's target the younger group. I'm not saying let's ignore the older, but we need to start targeting the primary group, which are the ages between 9 and 14, which is very, very critical for cervical cancer elimination. And this has been seen in much developed countries, in England, in Sweden, in Denmark, in Scotland, and other countries where they have followed this cohort for more than 10 years, and this is what we came out with. Now, in the population with HIV, it is showing that they have a very robust immune system for the HPV vaccine. So if you give it to them, it works. And then with time, the antibody declines, but it stays for a longer time. For some of them, it can stay up to 4 years, which is a good sign. And then we are saying that there's no obvious protection against reinfection by HPV virus when you receive the HPV vaccine for individuals with HIV. The data is limited. And in terms of children, that information is also limited. But the vaccine works. It shows that they develop immunity and then it's able to give them the right protection. The good news is that in African countries, we are introducing the vaccine and it's working. As such, today, we have about 35 countries out of our 47 member countries that have introduced the HPV vaccine. And most of them are going for the single dose schedule, which is shown to be effective among individuals who are not immunocompromised. So the good news is that countries are embracing the vaccine, and we need to keep up that momentum. Now, what is WHO saying? WHO has recommended that the vaccine should be given to young ladies between the ages of 9 and 14. In some countries, they are fighting for boys, but the primary targets are what? The young girls, because men, we don't have service. So the other ones are minor issues. We should target the primary group, and then afterwards, we can add up to the secondary groups. So the primary target is young girls, 9 to 14 years. And from the evidence, we saw that if you give it early, about 87% of cervical cancer cases will be averted. So it's very good for us. It's also recommended that at least you should get about 2 doses of the vaccine. But now we have come out with a single dose, which is shown to be as effective as the 2-dose schedule. So there's no need giving someone a second dose unless the person is what? Immunocompromised. But if the person is immunocompetent, then 1 dose is enough to give the required protection. So for individuals who are immunocompromised, 2 doses minimum, 3 doses, some countries can go for 4 doses, but at least they are required to get 2 doses. The problem we have now is that we are switching to 1 dose, we go to schools, we vaccinate them. Now, individuals who are immunocompromised, how do they get their 2nd dose? You've already told them that they need only 1 dose, so you vaccinate and you go back to the school that some individuals should get 2 doses. It will raise questions. Why are you getting 2 doses and I'm not getting? So privacy issues, confidentiality issues, and that is why we are asking that for us to get those individuals to get the 2 doses, we need to integrate our activities with the HIV/AIDS program, so that individuals who are coming for refill or ARC clinic, then they could be screened and probably get their 2nd doses. In view of this, we had a meeting recently, and then we gathered about 5 countries from the Southern Africa to deliberate over this. And these were some of the challenges that we came up with and the opportunities available. So from the next section, we'll be discussing some of these things to see how we can move forward. Thank you very much.
Panel discussion, and I have the honor to invite Dr. Frank Lule, who works at WHO's country office in Ghana, and also Dr. Angela Mushavi from Zimbabwe, Dr. Katie Ndaye from PATH, and also Dr. Ajay Ranjari from WHO. Dr. Lule, you will take it from here. Thank you.
Eva, thank you so much. And Barnabas, thank you for setting the scene. I know there are many questions that are being raised, but this is an opportunity for us to also listen to what is going on in countries and to also listen to partners that are supporting this initiative. So, as has been introduced, we have colleagues from Ministries of Health, Angela Mushavi. We have colleagues who are partners from PATH, from WHO. I have just very short questions, and I hope you have enough time to actually do justice to them. Let me start with government. Angela. There is a question here, and it is just about for you to help us really describe to us what is going on in Zimbabwe. For example, scaling up HPV vaccination within the HIV care platforms, and what lessons we can learn from it. 2 minutes, I'm sure is, oh, they said 4. Okay.
Thank you very much, Frank, for that question. And I just want to thank UNITAID at this point because there is some work going around HIV, HPV integration in Zimbabwe as well as in Mozambique through one of our implementing partners. And of course, I think as has been said from the presentation, obviously for girls that are living with HIV, they need 2 doses. Now Zimbabwe has moved to a 1-dose strategy from June of 2025. So it's a recent enough move. But remember, we already had girls that were being vaccinated, and prior to this transition, they were getting 2 doses. You know, even for those that are negative. And then the other ones, if they were positive, would get 3 doses. And I remember this morning saying, okay, what about the transition? And I was actually told, even before the 1-dose strategy, the girls who were on the 2 doses still want the 2 doses. because they got the information loud and clear that you need 2 doses. So they are finishing off with that cohort, and then for new clients, then we are now moving to the 1-dose strategy. Also, I want to highlight that on World AIDS Day, the Honorable Minister of Health and Child Care actually launched the HPV 1-dose, and also the HPV revitalization strategy. Now, what we have seen with the HPV-HIV integration, we needed to have a consultation with Ministry of Education, especially where you have got school-based, service delivery points. And then we also have the outreaches from facility to outreach. And then we also have within facility delivery. So what has happened for those receiving the single dose, either in outreach or at school-based points, if they are HIV positive, there was strong sentiment that they would be referred to facilities. So they would actually then be identified in a confidential manner, and then they would get their vaccination within HIV service delivery clinics or even in primary healthcare facilities. Now, their referral back to facility-based was facilitated by case care workers under Ministry of Social Welfare, by the school health masters, and in some instances by community adolescent treatment supporters or young mental mothers or village health workers within the community. They would actually help, even sometimes escort the ones that were living with HIV into what we call in Zimbabwe OI-ART clinics, or even primary healthcare clinics, for them to receive the second dose of vaccination. So the first dose is given when we have our grade 5 primary school or 10 years for out of school. And then the second dose for those that are living with HIV is happening between 6 months and 15 months after receiving the second dose. So that would be in grade 6 or at 11 years of age. So that's how we are doing it. The reason, I think, was very clear. If it's a school-based environment, one child gets the single dose and the other one comes back again for the second one, then the question they start asking is, but why are you getting the second one and I'm getting the first one? We've also leaned very heavily on some of the programs that were supporting orphans and vulnerable children at community level, as well as some of the DREAMS programs that were being funded previously through implementing partners supported through PEPFAR, and they would also do referrals of adolescents living with HIV who were eligible to receive the first dose or the second dose if they were living with HIV. That has been our experience. The issue around stigma was really highlighted for school-based giving of the second dose, and people still feel very strongly that to protect the confidentiality and not to bring about issues of stigma and discrimination, the second dose would be given in facility and really handled in a very sensitive manner to protect the children living with HIV, so that there is no accidental disclosure of their HIV status to colleagues and sometimes even to teachers who may not be aware of their HIV positive status. That's how we have been doing it so far. Thank you.
Thank you. Thank you so much. And I know there are many others in the room. I saw my program manager for the Ghana AIDS Control Program, the DG. Maybe when opportunity comes, they can also share. Dr. Kathy, PATH has been doing a lot of work in this area of HPV vaccination and also HIV care under your direction. Please share any lessons that you may have, particularly on integration, because it's one thing saying we need to do it, but the how is really important.
Sure.
Thank you so much for your question. Yes, I think across path work, supporting countries define how to integrate HIV services and HPV vaccination, we have a few lessons that stand out. I think the first one, the most important one, is that the integration needs to be country-led. And the delivery models should be co-designed between the immunization teams and the HIV delivery services. So HPV vaccination is, as you know, led by the immunization programs, and sometimes HIV teams are not involved from the start, from the planning phase. We shouldn't even wait until we are ready to vaccinate. When we are drafting the funding application, they should be there, right? When we are developing the vaccine introduction plan, they should be there. So we can discuss specifically what needs to be done for HIV-positive girls. We've already seen how they are more at risk. I think our colleague from Zimbabwe mentioned the stigma, the potential stigma when delivering vaccination at school. So ensuring that the two teams talk to each other and to avoid these problems, co-designing and building on existing HIV delivery platforms is essential. I think the second step, once we are done planning and we have funding now to do the work, it's to involve the HIV teams on during micro-planning. So it's during micro-planning that we define who will be vaccinating, where, when. Really, those simple questions that sometimes we don't think about because this is a priority population, special population, and we cannot treat them like the rest of the population. They need to be more specific discussion for HIV-positive girls. Third, I will mention simple data systems. Oftentimes, we aggregate data when it comes to HPV vaccination. We know there are maybe 2 million girls to be vaccinated. We reach 1.5, 1.8 million out of the 2. But we don't know if the HIV-positive girls were reached. So disaggregating data, ensuring that we have specific reporting on vaccination in this population, I think is really critical to know how well we are doing, are they being reached or not, and identify the gaps. And lastly, I think for integration to be effective, it needs to benefit both programs. We shouldn't integrate just to integrate. Usually, immunization teams should see that integration will increase uptake. HIV services need to see that integrating will help protect more girls. So really emphasizing the benefits for both programs can really be an incentive because they don't necessarily work together, but ensuring that they work together during technical working group meetings and that they plan together, define the budget together can really, really help. Thank you very much.
Thank you so much. You heard that, country-led, but we also need to have the data. And what I learned earlier this morning, if you don't measure something and you don't record it and you don't report it, you haven't done it. Thank you so much, Dr. Kathy. Ajay, it's your turn now. And maybe just for you to share with us any innovative ways that we can increase access, ways we can increase adherence, and even follow-up of HPV vaccination.
Thanks. And I think it's obviously a really important question because I think it represents the meeting of two very big global initiatives in some ways. And how do we make it make sense at the end user level? And I think particularly with HIV, we know that this population has higher risk. They're a vulnerable population. So I think especially when we start talking about data and digital tools, I think, I see there's sort of three major headings under which you can have the discussion. The first is, what are the digital innovations? So there's the process of identifying these. So for example, mHealth interventions are well established in HIV programs, you know, SMS reminders and so on and so forth. But now that's being used in cervical cancer programs as well. M-Health reminders are being used. But then we need to go one step further, because the second is having a strategy to engage with the community. And how does that happen? So for example, how would a digital intervention help with something like that? And that would be, for example, you use, you know, there's good use of the same SMS reminders or the same social media apps, because I think there are multiple uses for these various tools that we have at our disposal, because you could use it, for example, to predict risk of what is the person's risk of developing a cervical cancer lesion. The second is it giving the individual better awareness of themselves and understanding what risks they might have? The third is, does it give them information on where to go get screened? And then, of course, lastly, you would have to think about, is it adding any additional value? For example, is it capturing their attention? Because you have a group of adolescents, which is, I think my colleague earlier emphasized, those adolescent girls are the target group for the vaccination. So you obviously have to think about how do you engage them and make them aware of what the benefits of this dose is. Because I think, you know, some of the points raised earlier is this, there's concerns of stigma, there's concerns of particularly around giving that second dose, which is essential in women with HIV, because currently we don't have a lot of evidence on just giving a single dose. So how do you reduce stigma? By raising awareness. So if girls understand that it doesn't matter whether it's 1 or 2 doses, it's meant to ultimately protect and prevent disease. Again, so these tools have to be channeled in the right way. And then sort of the last, maybe sort of the last, is what is the infrastructure that's backing up all of this? So because again, we're talking about data, and data requires, there needs to be safeguards for such data. We're talking about a vulnerable cross-sectional population that is at risk of HPV-related disease, but also they have HIV as well. So how do you manage the safeguards around disclosure and various other issues that come up, and you know, ownership of data? There's so many questions. And I think there was another point raised by a colleague earlier, which is about digital interoperability, which is a very tedious word, but what effectively it says is that different facilities can view patient data and make appropriate healthcare related decisions. And the truth is that I don't think even the private sector, for example, has done a good job with interoperability, because if you go to most private hospitals, the surgical suite on one floor will be using a software that the internal medicine suite below cannot actually access. So, you know, it's hugely important, and I think at least from the WHO side, there has always been an emphasis of, you probably have heard of the person-centered strategic information guidelines. This really emphasizes that we are all speaking the same language when it comes to digital data. So we have the minimum data set, which tells countries what you need to be collecting at baseline in order to build indicators that might help your program in the future. So then we have the ability to compare and track progress and ultimately realize the various goals that we have set out. And then lastly, just to say, I think integration is sort of the sum total of all of the things I said. Essentially, if all of these components that I mentioned are working together, you have in a way integrated your services. So just, yeah.
Thank you. Thank you very much. I think a round of applause to our panelists. And over to you, Eva.
Thank you, Dr. Lule. Please remain at the podium, because we will soon have questions from the audience. But allow me also to say a few words of what we are doing in UNITAID, which was also mentioned by our colleague from Zimbabwe. So UNITAID, we have been investing about $100 million in secondary cervical cancer prevention since 2019. Our work is conducted in close collaboration with ministries of health. We started with 14 countries. Senegal and Zimbabwe were included. And now we are actually working in 26 countries worldwide, in the global south, of course. Our partners include WHO, CHAI, Expertise France, and more recently also Gavi. And I want also to highlight that we very much prioritize cooperation with communities and civil society on the cervical cancer work. So our activities include expanding equitable access to affordable and accurate HPV testing. We strive for and we promote self-sampling, self-collection of samples, and we use with portable thermal ablation treatment devices that are designed for low-income settings. So with this, we then strive to deliver integrated, scalable, people-centered models, particularly through platforms that are already being used by women, such as HIV platforms, primary healthcare platforms, and community platforms. So we have already reached more than 1.6 million women to access prevention services, secondary prevention services, and we have reached also, this has resulted to more than 1 million women being screened for cervical cancer. I mentioned Gavi. We are excited to increase our collaboration with Gavi as well, to see how we can integrate HPV vaccination with screening and treatment. And we have started doing this in Nigeria and Côte d'Ivoire. So this model will bring together Unitaid's market-shaping approach and our innovation approach with Gavi's excellence in developing vaccines, and not developing, but rolling out vaccines. So thank you for that little extra time. It is now time to open up the discussions. I believe we have a little bit more than 5 minutes. So please ask your questions, and please tell us also who you are and your name. And could we have some microphones, perhaps also to the speakers? Thank you, Dr. Lule.
Very good presentation. My name is Henry. I've worked for JSI. I currently do some work for UNAIDS. So I've worked in both HIV and then the HPV fields, and with Gavi activities in Ghana. There are 3 things I just want to call our attention to, and I like the presentation made by our lead presenter. But one of the key things that we should also carry along as we advocate more for control of HPV-related cancers is the whole issue about serotype 35. When you look at the nonavalent and the quadrivalent, it doesn't cover serotype 35, which seems to be one of the key ones among the 10 to 20%. You know, and every gynae oncologist that I've engaged with in the continent, especially in West Africa, is very keen on serotype 35. So our advocacy to MSD, to all these things, should be strong on that. And as in the continent, because this is ICASA, let me say that, we need to be pushing to look at what we want to do with that. Because that affects Black ancestry, women. 2, the integration of HPV and HIV, because I've worked in both sectors, this I will say will not be an easy task. And I'm listening because vaccination programs are typically vertical, and they deliver on what they want to do. But I think that, for example, when you look at Ghana, we use the spectrum to look at adolescents living with HIV, and we know the numbers. The total number, 400,000 general living with HIV. When you look at adolescents, it's very small, and could be a priority population. It's doable. And if this is passed on to the HPV program, they will know where they take their medications and can integrate at that facility level depending on the country. So I think that the information is available. If we drill from the HIV side, and we'll be able to focus on that. My last comment.
A quick one, please. Quick.
Okay. My last comment is, please, let us not forget the boys because of oropharyngeal cancer. If the public sector cannot fix that of the boys, because our priority is girls, for example, girls aged 9 to 14, That's fine. I've worked in the field and I know that is a priority. But please remember the boys, if you can get it from private sector, because of oropharyngeal cancers. Thank you.
Thank you so much. We have a second question.
Thank you very much. My name is Vivian from Zimbabwe, working with Shandiri. I'll try to make them short. My quick question is, thank you for the WHO colleague. Around the baseline data that you mentioned that you've got guidance for teams to collect, is it integrating HIV and cervical cancer, so HPV vaccination, so much that we can then easily track the integrated indicators? And my last one is to the facilitator around the eligibility criteria for access to self-testing for HPV vaccination, because the guidance for screening is focusing on 25 and above from WHO, and the young women are left behind. So the self-test kits, are you allowing them to access, or you're still targeting 25 and above? Thank you.
Thank you very much. Let's see if we have another question.
Thank you so much. My name is Sandra Morwera from Zimbabwe. I work for Zimtech. My question is to the facilitator regarding HPV testing. I would want to know the implementation barriers that are being faced in other countries compared to what we are facing in our country. We have challenges with turnaround time because we want to integrate with our HIV care, but we have sort of a slow process with the labs and everything. So when the woman then wants to have your result, it's not there on time, and this sort of affects implementation. What has been the experience with the other countries? Thank you.
Thank you. Yes, we have 5 minutes left, so last question over there very quickly.
All right, thank you very much. I want to thank the presenter. My name is Dr. Dugba Mwekara. I work with CHAI in Nigeria. During the presentation, you actually... Okay. The presenter talked more about, he was very, very concerned about age 9 to 14. And so I just want to know if, because this age is actually school age, we see them in either primary school or junior secondary schools. And I haven't been to the field. I also know that most times going to work in schools, there are some barriers. You meet some hesitation from the school authority. So just to know if we are doing some advocacy for government to have a policy in school health that makes it compulsory or makes it mandatory for children of that age to be vaccinated, because if you go to private schools, it's a different ball game from secondary school. So what do we do in such a situation, or what are we doing now? Thank you.
Maybe I'll answer the question on your question about the data-related question. So I think the point is that the person-centered strategic information guidelines is essentially the frame on which a country will design its data system, meaning which it helps the computer scientists who are developing the actual data structure to essentially embed certain bits of, headers. If you look at it, if you think of it as an Excel sheet, there's headers under which you would collect your data. And this essentially is telling countries those are the headers under which you should collect it. So since it is person-centered, your point on vaccination and any subsequent care should be included in this. That's why there is a minimum data set. So I would encourage you to have a look. It's an Excel file that's associated with the main WHO guideline that lists out everything. And then I think it's at this stage, once you've instituted that, for example, there are things known as digital adaptation kits that essentially allows coders to actually program, as in what are the alerts that will come from the program, or what is the clinical care pathway for somebody who is receiving a particular intervention. So it folds all of that in. So the idea is that it's meant to focus on the person and not the program. So by default, that data system is in a way integrated, if you want to say integrated, yeah.
we have some additional response from Zimbabwe.
Yeah, thank you so much. It was really to respond to the question on schools. And certainly going into schools, that's not the prerogative of Ministry of Health. It's under Ministry of Primary and Secondary Education. And these girls are young, you know, so they would be in primary education. However, within our head office in the Ministry of Health and Child Care, we've got a school health program. We also work with the Ministry of Public Service, Labor and Social Development, and then we integrate the National AIDS Council, and working collaboratively like that, we have developed a very strong school health strategy. And each of the schools has got a school health master. So the strategy is not developed in isolation, and through that strategy and the school health masters, our nurses in facilities work through to schedule appointments for vaccination in schools. I like your question about, does that mean everybody is forced to have the vaccination? We do have some parents who are very particular. They don't want their children to be vaccinated. And sometimes you find that in the very elite schools where the parents are now demonstrating a lot of this vaccine hesitancy. But by and large, the school health program is very successful because of the buy-in from the Ministry of Education. We also have in our incentives some people who for religious reasons don't want their children to be vaccinated, but by and large it's been a very successful program working through with the relevant ministries responsible for education. That's how we've done it in Zimbabwe. I just wanted to say, I know this wasn't a question, integration is easier said than done. You mentioned that we work with EPI program. We have to work with maternal newborn child health programs. We have to work with the Directorate of Nursing Services. We have to work with the AIDS and TB program. We have to work with the implementing partners and all of the people supporting us. And it's an active activity. You have to engage and work hard to do joint planning and joint even resource mobilization to make sure you have a successful integrated program. Thank you so much.
Thank you, Dr. Angela. So there is a lot of passion, and I think we could continue, but we actually have to stop this meeting now. But thanks to everyone for coming. We have had good discussions on how we can optimize HPV vaccination strategies for adolescents and women living with HIV in Africa. A lot of challenges. We discussed the stigma. We discussed the need for awareness. We discussed not to forget the boys. We also discussed about the need for data, the need for digital tools, infrastructure, how difficult it is with integration. But I think what's very clear is that this is a type of cancer that we can eliminate. So let's do it in partnership, and let's make sure that Africa can become cervical cancer free. Big hand to the panel, and thank you very much.